Hi, greetings to everyone. My name is Samyuktha and I'm a second year MBBS student. Yesterday's class was about muscles of scapula. I hope you all have watched that video. And today let us get to learn about the shoulder joint, okay? See, shoulder joint is an important essay question. So I want you all to listen to the class. Yes, let's get started. See, the shoulder joint is also called as the glenohumeral joint, okay? It is because, look here, this is a glenoid cavity. The glenoid cavity of scapula articulates with the head of humerus, and that is why the joint is also called as the glenohumeral joint. So here is the synopsis of today's class. See, for any joint you take, there are certain topics that you should mention compulsorily, and they are like type of joint, articulating surfaces, ligaments, relations, movements and muscles causing those movements, and clinical anatomy. These 6 topics will be repeated for every joint, okay? And apart from that, for shoulder joint, today we will be also looking at the rotator cuff. So this is all about the synopsis. And see, have a look at the image. I'm just going to tell you about the parts because I want you all to recall them for better understanding for further topics, okay? See, this is the scapula. It is not given completely, but it's okay. And this is your humerus, right? So this is your acromion process of the scapula, and this is your coracoid process of scapula. And this is your clavicle bone, right? It is articulating with the acromion process. And this is your glenoid cavity. And this is your humerus. So this is your head of humerus, and this is the greater tubercle, and this is your lesser tubercle, and this groove is your intertubercular groove, right? Yes. Next is your type of joint, okay? See, shoulder joint is a ball and socket type of synovial joint, and it is multi-axial. Look at the image here. See, this can be compared to the glenoid cavity. It is looking like a bowl or a socket, right? And so this is compared to the glenoid cavity, and this rounded part is your head of humerus. So this is compared to head of humerus. It is basically like fitting a ball inside a bowl, okay? So this is the ball and socket type of synovial joint, and it is multi-axial. Multi-axial in the sense all possible movements are possible here, okay? See, it is like flexion, extension, abduction, adduction, medial rotation, lateral rotation and circumduction. All these movements are possible in a ball and socket type of synovial joint, and that is applicable for the shoulder joint as well. Okay, so this is about the type of joint. Next is your articulating surfaces. Articulating surfaces here for shoulder joint are this glenoid cavity or the glenoid fossa and the head of humerus. Okay, these both articulates to form the shoulder joint. And see, have a look at the image. See, this is your glenoid cavity and this is your head of humerus. Glenoid cavity is a shallow depression and it is faced laterally. And your head of humerus is a rounded part and it is faced medially. Okay, so this is all about your articulating surfaces. Next, we'll talk about the ligaments. See, I'll first list out the ligaments so that you get to familiar with those names, and then we will have a look at the image and then in detail about them. Okay. See, fibrous capsule, glenoid labrum, glenohumeral ligament, coracohumeral ligament, transverse humeral ligament, coracoacromial ligament, and coracoacromial arch. For ligaments, from the name itself, we'll be able to derive its attachments. Okay. Similarly, for shoulder joint also, from its name itself, you are going to tell the attachments. Have a look at the image. See, this outermost green colored part is there, right? This is the capsule of shoulder joint, the capsular ligament or the fibrous capsule. Okay, this basically covers the entire joint, this actually connects bit from the glenoid cavity and the head of humerus. So it is going to cover the entire joint. See, the entire joint will be covered by the capsule of shoulder joint. And next, see, look at this. These are 3 bands, right? So these are your glenohumeral ligaments. From the name itself, we'll be able to tell glenohumeral, right? So it is going to extend from the glenoid cavity to the humerus bone. So this is your superior glenohumeral ligament, this is your middle glenohumeral ligament, and this is your inferior glenohumeral ligament. See, this is your glenoid cavity, and this blue colored outer part is there, right? This is your glenoid labrum. Glenoid labrum is a fibrocartilage and it is getting attached to the glenoid cavity. So it is actually covering the glenoid cavity completely. See, next is your transverse humeral ligament. See, transverse humeral, right? So it is basically going to transverse between some two parts of the humerus bone. Here the two parts are your greater tubercle and the lesser tubercle. So the transverse humeral ligament is going to extend from the greater tubercle ligament to the lesser tubercle ligament, and below this ligament the tendon of long head of biceps brachii is going to pass through, and that part is called as the intertubercular sulcus or the intertubercular groove. Okay, so we had the glenohumeral ligament and transverse humeral ligament here, right? Next, see, this is the coracohumeral ligament. From the name itself, it is from the coracoid process to the humerus, right? So this green color part is your coracohumeral ligament, and look at here, the white part, right? This is actually your glenohumeral ligament. See, from the glenoid cavity to the humerus, right? So this is your glenohumeral ligament. And next, see, this is your coracoacromial ligament, from the coracoid process to the acromion process. So this is your coracoacromial ligament, and all these three together, the coracoid process, the coracoacromial ligament and the acromion process, all these three together are called as the coracoacromial arch. Now let us look in detail about each ligaments. Fibrous capsule, it surrounds the margins of glenoid cavity and head of humerus. The glenoid labrum, it surrounds the glenoid cavity, and this is made of fibrocartilage. Okay, and the glenohumeral ligament, it extends from the glenoid cavity of scapula to the humerus, and this is formed by the thickening of fibrous capsule, and it is of three types. Okay, superior glenohumeral ligament, middle glenohumeral ligament and inferior glenohumeral ligament. Next is your transverse humeral ligament. See, it transversely extends between the greater tubercle and the lesser tubercle of humerus. Okay. Next is your coracohumeral ligament. So coracohumeral ligament extends from the coracoid process of scapula to the anatomical neck of humerus, and this is a part of the pectoralis minor muscle, because the pectoralis minor actually gets inserted into the coracoid process, right? So that is why this is a part of the pectoralis minor muscle. Okay. Yes, the coracoacromial ligament extends between the coracoid process and the acromion process of scapula. And next is your coracoacromial arch. Coracoacromial arch is a combination of the coracoid process, acromion process and the coracoacromial ligament, and this actually it is formed and superiorly, right? So it is going to prevent superior dislocation, so it is going to provide support superiorly. Okay, yes, that is why it is going to prevent the superior dislocation of the shoulder joint. See, this is your acromion process and this is your coracoid process, and this white color is your coracoacromial ligament. All these three together is your coracoacromial arch. It is formed superiorly, so it is going to provide support and it prevents superior dislocation of the shoulder joint. Okay. Next, we'll have a look at the relation. See this diagram, you must practice this because you need to draw this in your exam. Okay. So relations you will be writing in 5. Okay. Superior, anterior, posterior and inferior. I see there is a marking in the side also. This is the superior region, right? So this is your inferior region, this is your anterior region and this is your posterior region, and this is within the capsule. So this is actually the blue color is your capsule of shoulder joint. Okay, first we'll have a look at the superior relations. See, the acromion process, coracoacromial ligament and your coracoid process. So all these three together is your coracoacromial arch, right? So this is your first superior relation. Next, you should write the supraspinatus. Supraspinatus is your next relation along with the subacromial bursa. Okay, so the coracoacromial ligament, supraspinatus and your subacromial bursa. These three forms your superior relations. Coming to the inferior relations, your long head of triceps muscle and a nerve and some vessels. Okay, the long head of triceps, axillary nerve and posterior circumflex humeral vessels forms your inferior relations. In this diagram only artery is marked, but actually artery and vein both accompanies together. Okay, so you can also draw a blue line here and mark it as posterior circumflex humeral vein. Okay, so your inferior relations are going to be long head of triceps, axillary nerve and posterior circumflex humeral vessels. Okay, Coming to the anterior relations, the anterior most part is your anterior fibers of the deltoid. Okay, so anterior fibers of deltoid is your first anterior relation. Next, we have biceps and coracobrachialis. See, biceps, it is actually short head of biceps brachii, because the short head of biceps brachii and coracobrachialis originates together, right, from the coracoid process. So these both should be mentioned together. And next is your subscapularis. So these three forms your anterior relations. Coming to the posterior relations, the posterior most muscle is your posterior fibers of your deltoid. Okay, so this is your first posterior relation, and next is your infraspinatus and teres minor. Okay, so these three are going to form the posterior relations. And this pink color part is your glenoid labrum, and this blue color is the capsule of shoulder joint. See, there is a projection here, right? A green color projection. This is actually the tendon of long head of biceps brachii. So the tendon of long head of biceps brachii is intracapsular, which means that the long head of biceps is actually originating within the capsule itself. Okay, so this is about the relations. See, it's just put in words. Superiorly, we had the coracoacromial ligament and the arch, and we had the supraspinatus muscle and subacromial bursa. We also have the acromial fibers of the deltoid, which was actually not given in the image, but if you want, you can write this additionally. Okay. Inferiorly, we have the long head of triceps brachii, axillary nerve, and posterior circumflex humeral vessels. Anteriorly, we had the anterior fibers of deltoid, and then the short head of biceps brachii and coracobrachialis together, and then the subscapularis muscle. And posteriorly, we had the posterior fibers of deltoid first, then infraspinatus above and teres minor below. So this is the posterior relation. And within the joint, we saw the tendon of long head of biceps brachii, right? So this is the one which actually passes in the intertubercular sulcus. I already told you, right, in the ligaments diagram. Below the transverse humeral ligament, in the intertubercular sulcus passes the tendon of long head of biceps brachii. Okay, so this is all about the relations. Next, we look at the movements. See, shoulder joint is the most mobile joint, and it is least stable also. Okay, so because it is least stable, it is more prone to injury or the dislocations. I already told you, since it is a ball and socket type of synovial joint, all types of movements are possible in a shoulder joint. So all the movements, flexion, extension, abduction, adduction, medial rotation and lateral rotation and circumduction, all these 7 movements are possible in a shoulder joint. First, we look at the flexion, extension and abduction, adduction. Okay, see, flexion is moving your entire arm forwards and medially, and the opposite is your extension, backwards and laterally. Okay, so this is flexion and this is extension. Coming to abduction and adduction, abduction is moving your entire arm away from the trunk. Okay, and from the abducted position, moving your entire arm towards the trunk is your adduction. You can remember it like this. Adduction has add in it, right? ADD, add. So add in the sense you're going to add your arm to your trunk. So this is adduction. And away from the trunk is your abduction. Okay, so this is flexion, extension and abduction and adduction. Next, we'll come to medial rotation and lateral rotation. For medial rotation and lateral rotation, your elbow. So this is the point of elbow, right? The elbow should be at semi-flexed position. Okay. So after having your elbow at semi-flexed position, you're going to move your arm and you're going to move your forearm and wrist towards medially, and that is going to be your medial rotation. And away and moving your forearm and wrist laterally is going to be your lateral rotation. Okay, so this all happens at semi-flexed elbow. Next is your circumduction. Circumduction is actually the combination of all the other movements. Okay, so it is basically like rotating your entire arm sideways. Okay, so this is all about the movements. So, and these are the muscles that causes movements. I have highlighted the main muscles that you should mention. Okay, we'll have a look at the muscles as well. See, for flexion, pectoralis major is the most important muscle, and you should be writing this. And the other muscle that assists are the anterior fibers of deltoid, biceps brachii and coracobrachialis. So all these 4 muscles are going to cause flexion. Okay, next is your extension. For extension, latissimus dorsi is the most important muscle, and the other muscle that assists is your posterior fibers of deltoid. For extension, it is these two. Okay, latissimus dorsi and posterior fibers of deltoid. For adduction, you need to write three muscles: pectoralis major, latissimus dorsi and teres major. So these three muscles for your adduction. Abduction I'll teach you in the next slide because it actually occurs at three ranges. Okay, so we'll look at it later. Next is your medial rotation. For medial rotation, the main muscle is your subscapularis, and the other one you should write, the muscle that assists is your anterior fibers of deltoid. Okay, and for lateral rotation, we have the posterior fibers of deltoid, infraspinatus and teres minor. Basically, these three forms your posterior relations, right? So they all three actually causes lateral rotation as well. Okay, so this is all about the muscles that causes the corresponding movements. If you want, you can take a screenshot of this, or as I told you, just mention in your notebook or anywhere. You need to write this in your exam. Okay, and next we'll come talk about the abduction. Abduction occurs at three ranges. Okay, the first range is your initiation of abduction, and that is your 0 to 15 degree abduction movement, and next is your 15 to 90 degree abduction movement, and the third one is your overhead abduction, which is 90 to 180 degree. Okay, so the muscle responsible for 0 to 15 degree movement is your supraspinatus, and for 15 to 90 degree is your acromion fibers of the deltoid muscle. Okay, for overhead abduction, serratus anterior and trapezius, both these muscles are responsible for overhead abduction. Okay, so this is about abduction. Abduction occurs at three ranges. Okay, 0 to 15, 15 to 90 and overhead abduction 90 to 180. Yes, we have completed the movements. Next, we'll have a look at the rotator cuff or the musculotendinous cuff. Okay, rotator cuff can be asked as a 5-mark question as well. And this diagram is important. You need to practice this also. You need to draw this in your exam. Okay. Yes. See, rotator cuff is actually formed by tendons of 4 muscles. Okay. These 4 muscles fuse with the fibrous capsule and they form the rotator cuff. Okay. These 4 muscles are the sits muscles. S-I-T-S. Sits muscles. Okay. S for supraspinatus, I for infraspinatus, T for teres minor, and the last one S for subscapularis. Okay, S-I-T-S. The supraspinatus is located superiorly. Infraspinatus and teres minor both are located posteriorly, and the subscapularis is located anteriorly. See, inferiorly there is no muscle that gets fused with the capsule of shoulder joint. Okay, there is no muscle here getting fused with the capsule of shoulder joint. Just remember this because we have a clinical related to this. Okay, so this is the 4 muscles that forms the rotator cuff, and these 4 muscles, the sits muscles, gets inserted into the tubercles of humerus bone. Okay, so this is your greater tubercle and lesser tubercle, right? And this is your intertubercular groove or the intertubercular sulcus. So SIT, sit, these 3 muscles get inserted to the greater tubercle of humerus. Okay, supraspinatus, infraspinatus and teres minor, in the same order they get inserted to the greater tubercle, and the subscapularis gets inserted to the lesser tubercle. Okay, so and in the intertubercular groove only, I already told you, right, the tendon of long head of biceps brachii passes through, and the ligament that connects these two tubercles are what? The transverse humeral ligament. Okay, so this is basically the representation how they get inserted, and have a look at this, and this is actually your left side humerus bone. Okay, see, this is your left side humerus bone, it's marked here, and this is how they get inserted. And the clinical importance is that they provide support and they prevent dislocation of the shoulder joint. And the disadvantage is that they provide support in all directions except inferiorly, right? I already told you in this diagram. I told you to remember, right? See, there is no muscle that gets fused with the capsule of shoulder joint inferiorly. So that is why this is not going to provide support inferiorly, okay? And that is why inferior dislocation of shoulder joint is very common. It is very common. And then we have an applied anatomy. The most common rotator cuff injury is due to the rupture of supraspinatus tendon. Supraspinatus is the muscle that is responsible for abduction. Abduction, initiation of abduction, right? So from 0 to 15 degree that movement is responsible by supraspinatus. So due to the rupture of its tendon, we will be having the difficulty in initiating the abduction. Okay, from 0 to 15 degree movement of abduction will be difficult. See, this is the image. This is your supraspinatus muscle and this is your tendon. Here it is getting injured. So because of this, the patient will not be able to abduct his arm from 0 to 15 degree. Okay, yes. Next is your last topic for shoulder joint. This is your clinical anatomy. See, for clinical anatomy, for any joint, first thing we will be writing is the dislocation. Here in shoulder joint, the most common dislocation occurs inferiorly because I already told you there is no inferior support, right? So yes, that is why most commonly injury occurs inferiorly, and because of inferior dislocation, it leads to axillary nerve injury. See, in relations, we saw that the axillary nerve, posterior circumflex humeral vessels and long head of triceps forms your inferior relations, right? So due to inferior dislocation, the axillary nerve will get injured, and because of this, it leads to paralysis of the deltoid and teres minor muscle, because your axillary nerve supplies the deltoid and teres minor muscle, right? So that is why it leads to paralysis of both these muscles. So this is about the inferior dislocation of shoulder joint. And we also have other two applied. You can also write this for your rotator cuff. Okay, so it is painful arc syndrome. In this, pain is experienced during the abduction movement, and it is most commonly due to the supraspinatus tendon injury. And the other one is the frozen shoulder. It is due to inflammation of all the tendons forming the rotator cuff. See, the painful arc syndrome is nothing but just, it's basically the rotator cuff injury. Okay, because we saw the most common rotator cuff injury is because of the injury to supraspinatus tendon, right? So you can also write this for your rotator cuff if it is asked in a 5-mark question. So these three are your clinical anatomy for shoulder joint. And summarizing the entire topic today, the type of joint we saw, it was ball and socket type of synovial joint. Next is your articulating surfaces. Articulating surfaces was your glenoid cavity of scapula and head of humerus. Okay, and ligaments, we had a big list. So it was the fibrous capsule, glenoid labrum, glenohumeral ligament, coracohumeral ligament, and it was coracoacromial arch and coracoacromial ligament, and we also had the transverse humeral ligament, right? Yes, so these are the ligaments. And then relations, you need to mention superior relations, inferior relations, anterior relation and posterior relation. Then within the joint, okay, within the joint we had the long head of triceps brachii. Sorry, it was not triceps, the long head of biceps brachii. Okay, so this was about the relations. And next was your movement and muscles causing those movements. Movements where the all possible movements are possible: abduction, adduction, lateral rotation and medial rotation, flexion, extension and circumduction. And the muscles causing those movements, I gave you the chart, right? And for abduction alone, it occurs at 3 ranges. And next is your rotator cuff, which is formed by the sits muscle. S for supraspinatus, I for infraspinatus, T for teres minor, and S for subscapularis. Then we had a look at the clinical anatomy. So this is all about the shoulder joint. I hope you all understood the topic, and if you have any doubts regarding the topic, you can leave it in the comment box and we will get back to you. Okay, so yeah, thank you.